So dear friends, today's topic will be on the microvascular complications of the diabetes. So the basic pathology, here the progressive narrowing and occlusion of the vascular lumina that lead to impaired perfusion, so ischemia, and finally tissue damage. So this can apply for all the three microvascular complications and also to your macrovascular complications. So the progressive narrowing and occlusion of the vascular lumina leads to the impaired perfusion and then the ischemia and finally tissue damage. So tissue damage in the retina will cause retinopathy. Tissue damage at your renal level causes nephropathy, and tissue damage at your neurological level, neuropathy. Okay. So these are the cells commonly involved here. The retina endothelial cells, pericytes, Muller cells, and the ganglion cells. In the renal, you have the mesangial cells and the podocytes. Already we discussed this. And the peripheral nerves, Schwann cells, endothelial cells, and the pericytes. With the chronic hyperglycemia, so uncontrolled chronic hyperglycemia, so these are the different pathways to cause the microvascular complications or the vascular complications. That the polyl pathway, ACE pathway, that advanced glycation and products pathway, PKC pathway, and exosamine pathway. Polyl pathway, there is the reduced levels of the reduced glutathione. ACE, you have the activation of the advanced glycation as end products receptors. There will be the modification of the intracellular proteins, increase the levels of the pro-inflammatory cytokines. PKC pathway, nitric oxide, that is a good vasodilator in the vessels. So once it is reduced, it causes more of vasoconstriction. And there will be the increased levels of the pro-inflammatory cytokines. On the exosamine pathway, you will have the altered gene expression, N-acetyl glucosamine, and again the pro-inflammatory cytokines. So these are the different pathways which can be aggravated in the presence of your microvascular complications. So already we discussed the diabetic kidney disease. That diabetic kidney is defined based on the presence of albuminuria and or reduced GFR, either or both. So either albuminuria, either GFR reduction, or both. In the absence of the signs or symptoms of other primary causes of the kidney damage. So when you are diagnosing the DKD, you have to exclude the other causes of the kidney damage. Most patients will have the long-standing duration of the diabetes and the concomitant retinopathy, because retina and the glomeruli, they are very good friends. So all the neuropathy or nephropathy population will have some amount of the retinopathy. In the same way, the severe retinopathy will have some amount of the nephropathy. So the magnitude of the problem is a very big problem in India. 20 to 40% of the patients with the diabetes will have the DKD. So 20 to 40% of the patients with the diabetes means there are 10.5 crores of the diabetes in India. So 20 to 40% means very high numbers. Usually occurs in the type 1 diabetes after 10 years of the disease onset, but may be present at the time of the diagnosis in the type 2 diabetes. In type 1 diabetes, it is a virgin disease. No complication at the time of the diagnosis of the type 1 diabetes. All the complications following the diagnosis of the type 1 diabetes, depending on the duration of the diabetes and control of the diabetes. Whereas the type 2 diabetes, even 40 to 50% of the type 2 diabetic patients, they present with the complications at the time of the diagnosis itself. See, if you see the duration of the diabetes, 10 years, they will get the DKD. So usually, type 1 diabetes occurs at the age of 12 years, or 10 years, or 8 years, or 15 years, less than the 20 years. Suppose after 10 years, if they get the DKD, that means at the age of 20 or 25, 30 years, they get the DKD. And at the age of 35 years, they are on the dialysis therapy or the transplantation. And if they left untreated, usually they die before the 40th birthday. So the type 1 diabetes is very, very, very important to keep the blood sugars very tight to around the 6.5. But it is very easy to say, but it is very, very difficult to treat young individuals, especially the children, adolescents, and young adults, to maintain the euglycemia irrespective of their food habits and the physical activity. So it's the leading cause of the end-stage renal disease across the world in general and in India in particular. In India, only two reasons for your end-stage renal disease. One is diabetes, second one is hypertension. Patients with DKD are also at high risk of dying due to the cardiovascular disease. I told you, no, even at the third stage of your DKD, more and more people will present with the ischemic heart disease. Migrant study suggests that Asian Indians with diabetes have higher risk of kidney disease compared to white Caucasians. So our people are having more DKD also. High economic burden on the society because a lot of money is involved to get your urea, creatinine, electrolytes, etc., anemia, erythropoietin, and then the calcium. Okay, lifelong. So they are very important. They are at high risk of getting the metabolic acidosis, DKA. They are at high risk of getting the hypoglycemia, frequent admissions. So admissions in the ICUs. So these are very, very important in the DKD population. So economical burden on the society. So these are all the risk factors for the diabetic kidney disease. So whenever you see the diabetic kidney disease, you please concentrate on these risk factors. If the person is also in hypertensive, control effectively. Hyperglycemia, so the blood sugars has to be controlled. Duration of the diabetes, you can't do anything, but it gives you an idea that so a chronic duration of the diabetes definitely have the complications. So try to address these complications, try to involve the etiology of these complications and correct them. We can't do anything about the family history. So ethnicity is also we can't do anything, but cigarette smoking in any form has to be stopped. Hyperlipidemia, you can use the statins, you can use the fenofibrate, you can use the bambudoic acid, you can use the HTMI. So to reduce your hyperlipidemia, analgesic abuse has to be stopped because most of the Indian population RMPs, they use analgesics left and right. For everything they use the analgesics and the steroids. So these two are very, very dangerous for the kidneys. So involves the multiple kidney compartments, not the glomerulus alone. So not only the glomerulus, your tubules also will be involved here. Earliest constant change is thickening of the glomerular basement membrane, 1.5 to 2 years after the onset of the type 1 diabetes. Just after the 2 years of the type 1 diabetes, start increasing the glomerular basement membrane. Thickening, accompanied by the capillary and the tubular basement membrane thickening, followed by the loss of the endothelial fenestrations, mesangial matrix expansion, and loss of the podocytes with effacement of the food processes. They are the 5 to 7 years after the onset. And next step is the segmental mesangiolysis, the development of the Kimmelstein-Wilson lesions. So there is a nodular glomerulosclerosis. This is the most specific, but it is not common. Not common Kimmelstein-Wilson lesion. What is more common is the extensive glomerulosclerosis, not the nodular glomerulosclerosis. But nodular glomerulosclerosis is the KW lesion that is more specific for the diabetes. And the most specific for the diabetic glomerulopathy, they are not uncommon. They are not common. Structural changes, there is a subendothelial deposition of the plasma proteins, which can compromise the lumen of the small arterial branches, arterioles, and glomerular capillaries. Subepithelial deposits appear as the capsular drops. Later stages involve the coalescence of the interstitial and the glomerular changes, leading to the segmental and the global sclerosis. Structural changes are there. So these are all the mesangial expansion, basement membrane thickening, and the podocyte foot process. This slide already showed you. Diabetic tubulopathy, not only your glomerulopathy, here the tubulopathy. Recent evidence suggests that proximal tubular epithelial cell may play an important role in the development and progression of the kidney disease and the diabetes. Proteinuria induces the expression of the various pro-inflammatory and pro-fibrotic markers. These pathways can lead to the progressive interstitial inflammation and the fibrosis. Renal function in the glomerular disease correlates more with the extent of the tubulointerstitial damage than of the glomerulopathy. So these are the different stages. Stage 1, GFR is more than the 90. Stage 2, where it is about 60 to 90. Stage 3, about 30 to 60. Again divided into stage A and B. Stage 4, 15 to 30. And stage 5 less than the 50. See what is here. In the stage 1, there will be the hyperfiltration and the hypertrophy. Stage 2, normoalbuminuria. Stage 3, microalbuminuria. Stage 4, overt proteinuria. Most of the people, they are asymptomatic, even at the level of the overt proteinuria. So that means we are not diagnosing the CKD in the early stages. By the time they are the symptomatic, they are already in the stage 5 or at the stage 4. So our duty is to pick up the people at the level of the microalbuminuria or the proteinuria levels. So then only we can prolong the progression of the, we can arrest the progression or we can slow down the progression of the CKD population. See, this is the hallmark of the diabetic glomerulopathy, abnormal albumin excretion. It is reversible if detected and managed when the albumin excretion is only moderately elevated. This is a reversible one. So provided if you diagnose at the level of the microalbuminuria, once it is a proteinuria, it is not a reversible one. So test for albuminuria annually in all patients with type 2 diabetes starting at the diagnosis. So starting on the diabetes de novo, you have to get the microalbuminuria. So this is the already these told you the numbers A1, A2, A3, A1 normal to the mildly increased albumin excretion. Okay, so normal is less than 30 and 30 to 300 you can consider as an abnormal, and A2 moderately increased albumin excretion, that is a microalbuminuria, and A3 severely more than the 300. So even more than the 300 is severely. So a lot of the people will have the 1 gram, 2 grams, 3 grams also. 24 hours urine excretion, urine albumin estimation. Most of our people will have 1 gram, 2 grams, 3 grams also. That means a lot of the albuminuria. That means there are very high risk of progression to the CKD. So this is the case one, 50-year-old, type 2 diabetes for the last 15 years. So he got the diabetes at the age of 35 years. Now already 15 years. On OHA, sulfonylureas plus metformin, presenting with the polyuria. BP 160 by 100, weight 70 kgs, height 164 centimeters. Fasting 210, A1C 11.7, albuminuria 1 gram per day, retinal examination, NPDR, both eyes. So what is your working diagnosis? See, at the age of 50 years, a 15 years history of the diabetic life. The working diagnosis here is already diabetic, is an hypertensive, the BP is 160 by 100, is also having albuminuria, that is nephropathy, and also having retinopathy. Okay, so this is diabetes plus hypertension plus diabetic nephropathy and diabetic retinopathy. So what is your provisional diagnosis? This is the provisional diagnosis. What further investigations is to be done? So don't be happy that diagnosing the two complications. So he might be having also the ischemic heart disease. He might be having the peripheral vascular disease. So that also you have to be, yes, dyslipidemia, etc. So how will you manage the patient? So here are the 4 parameters. One is the diabetes. Is the diabetes has good control? No. The fasting is 210. HbA1c is 11.7. So 11.7 means you need, excellent. So start insulin here to control the blood sugars very effectively. And whatever the metformin, so respect the metformin according to the creatinine levels. Here the creatinine level is not there. So get the creatinine levels good. Check the creatinine level, get the GFR and adjust the dose of the metformin accordingly. So already the patient is in nephropathy. So don't use the sulfonylureas preferably. Suppose if you want to use the sulfonylureas, suppose he is getting the glibenclamide, change to the glipizide. Otherwise stop using the sulfonylureas. Go to the gliptins or go to the SGLT inhibitors according to your creatinine levels. That is how you manage the diabetes here. Number 2, hypertension. So here the blood pressure is 160 by 100. So here you have to use the drugs. What are the compelling drugs to use the hypertension in the diabetic individuals? AS or ARBs. So you can use either AS or the ARBs because it's the type 2 diabetes. Usually we use AS in ARBs. ARBs means your telmisartan or the olmesartan. So preferably you can use the telmisartan here. So what is the dose of the telmisartan? You start here. Is it 20 milligrams or 40 milligrams or 80 milligrams? So you can start with the 40 milligrams. Is telmisartan alone is sufficient or some combination is also needed? So you need a combination drug therapy because it is the second stage. Hypertension is divided into 3 stages. Stage 1, stage 2, stage 3. Stage 1 means 140 to 160 systolic, 90 to 100 diastolic. Stage 2, 160 to 180 systolic, 100 to 110 diastolic. Stage 3 means systolic more than 180, diastolic more than 110. So it is the stage 2. So stage 2 means you need 2 drugs. So combination drugs. So already you are using ARB, you can add diuretic here, or you can add calcium channel blocker. It is up to you. So that's how usually we add the diuretic before the calcium channel blocker. So either you can use the chlorthalidone or hydrochlorothiazide according to your GFR, again according to your GFR. Suppose if your GFR is 45 or the 30, you can use the chlorthalidone. Suppose if the GFR is 60 or the 70, or you can use the hydrochlorothiazide. That is how you have to adjust the chlorthalidone or the hydrochlorothiazide. But chlorthalidone is much superior to the hydrochlorothiazide in reducing your parameters like LVH also. So that is the second part. So first part, diabetes good control. Number 2, hypertension good control. Number 3, albuminuria. Okay. So here the albuminuria is 1 gram. 1 gram is very high. So how to treat albuminuria? So one is your ACE inhibitors or ARBs. Again and again you are using the ARB. And then your food. So your nutritional approach, and then your physical activity, and then cessation of the smoking. And if the person is overweight, so reduce the overweight activity. And then you can use the some other drugs like your phenerenone you can use here, or you can use the phenerenone can be a good choice here to use to reduce the albuminuria here. So that is how we have to treat the albuminuria part. And then the fourth one is retina. Retina is NPDR. NPDR is not a dangerous one. So these people will go into the PDR, left untreated. So NPDR treatment means treatment of the diabetes, treatment of the hypertension, treatment of the lipids, or treatment of the other comorbidities, and then cessation of the smoking, etc. So that is how you have to get the NPDR, and advise the patient every 6 months or every 1 year you check the retina. When the patient is entered into the proliferative diabetic retinopathy, laser therapy and interventions will start as per the retinal interventions by the retina specialist will be started at the time of entering into the PDR. Otherwise, these people will have retinal detachment, okay, or sudden vision loss, etc. So that is how you have to treat. Am I clear in this patient? So that is how practically you have to follow that. The 4 diseases here, 4 treatment aspects I told you. On the 5th and 6th and 7th, you have to recognize, you have to tell you. So here the dyslipidem is not there. Check the lipid profile. Here the renal function is not there. Check the renal function. Here the fatty liver is not there. SGPT, SGOT, etc. Check the fatty liver. That is your liver profile. And then here uric acid is not there. Check the uric acid. Suppose if uric acid is 10, 11, 12. So reduce the uric acid also. Provided if the uric acid is 6.5 or the 7. So don't bother. In the dietary restrictions, you can change over to the uric acid to the normal levels. So that is how you have to treat it. Am I clear? So yes. So this is the GFR formula. You need not remember these formulas. Now you have the smartphones, you have the apps to there. So the same thing I told you. So on the one hand you have the GFR, on the other hand you have the albuminuria. See the redness, very dark redness. So these are all very high risk individuals. What are the causes of sudden drop in GFR? So you have been following the patient for the last few years. All these years, the creatinine level is 2.5 or 2.6 or 2.7, etc. Suddenly, the creatinine level has gone up to 5 or the 6 or the 7. So, what are the reasons for that? One is dehydration. Obstructive uropathy, very, very common. So, prostatitis or BPH or any nephrolithiasis or ureterolithiasis or sometimes a vesicoureteric reflux or sometimes malignancies, especially in the females, carcinoma cervix or endometrial malignancies, sometimes tumors brushing over those areas. So obstructive uropathy is a very, very important. Here we have to take the advice of the Dikshitulu as a senior urologist. So you see the obstruction part. This is also very, very important. And then use of the drugs. So they are the nephrotoxic drugs, especially aminoglycosides. So your amikacin, your gentamicin, used left and right by our general practitioners and the RMPs. So avoid those drugs. NACIARs, avoid those drugs. Suppose if the patient is for the contrast therapy, contrast radiological things. So you have to respect the kidney function there. Otherwise, these people will have the sudden drop in the GFR because of the elevation of your creatinine levels. So these are very, very important. And then the fibrates, I told you earlier also, fibrate therapy. So fibrates will increase your creatinine levels. So don't combine the statins and the fibrates in the presence of the renal failure when the creatinine level is higher up. So when the creatinine level is normal, you can combine these two. Otherwise, don't combine it. And then the certain antibodies, already told you, aminoglycosides, indigenous medication. These are also very common in India. So Bhotavaijam, Ayurvedam, etc. They contain a lot of the metals. So again, they are all nephrotoxic. Recent initiation of the SGLT2 inhibitors or ACE or ARB without knowing your creatinine levels. Suppose in the baseline the creatinine level is 2, you are already started with the telmisartan. So what will happen to your creatinine level? The creatinine will develop, will increase. So that is there. Even at the normal creatinine levels also, once you use the ACE inhibitors or ARBs, there may be a little bit hike in the creatinine levels in the initial days, and after the prolonged usage, again they come down. Okay. Usually self-limiting. Infections, especially those of the urinary tract. See, the urinary tract infections are very, very, very common in our diabetic individuals, especially the females because of short urethra. So very good perianal and hygiene is very, very important to prevent the urinary tract infection. They can be divided into uncomplicated UTI, complicated UTI, uncomplicated lower urinary tract, uncomplicated upper urinary tract, and then your pyelonephritis. Sometimes you will have the recurrent UTI, you have the relapsed UTI, you have the reinfection UTI. So these are different. Recurrent UTI means same UTI. So even at the end of the your total therapy, relapse means after maybe 2 weeks or 3 weeks of your continuous antibiotic therapy, same relapse means same organism will come there. Reinfection. So this time another infection, another bacteria. So most of the times in E. coli, most of the times it is in a Klebsiella, most of the times it is your Enterobacteriaceae. So sometimes Pseudomonas will come up. Sometimes it may be Streptococci will come up. So this is the reinfection means with the another organism. So the UTI is a very big topic, and every diabetologist should know everything about the UTI. So if time permits, at the end of the show, our lectures, I would like to talk on the UTI also. Very, very common because left untreated. So these will go the ascending infections. So these UTIs will cause pyelonephritis, and then the pyocele, and then sometimes we have to we have to resect the kidneys also. So if you use the radio contrast material, so no dye is entered into the right kidney. Left kidney, good entry. Right kidney, no entry. That means non-functioning kidney. So you have to sacrifice that. Otherwise, a lot of the pus will be there, and then the patient will go into the sepsis, multi-organ failure, and also the death. So this is a very, very, but don't underestimate the importance of the urinary tract infection treatment in a diabetic individuals. So you have to use the drugs. Again, you have the 3 types of the resistance in UTI in India. One is the MDR resistance, multi-drug resistance. That means commonly used antibiotics. They are the resistant, like your fluoroquinolones or your nitrofurantoin, etc. And then extended drug resistance. That means most of the drugs, even your cephalosporins or if the ceftazidime, these are also resistant. And then pan resistance. Pan resistance means every drug will be resistant. So most of the people we are having about 60 to 70% of the UTIs in India, they are the multi-drug resistant. Multi-drug resistant, extended drug resistant, and then the pan drug resistant. So to tackle this resistance, you need a lot of courage, you need a lot of the basic understanding of the UTI, you need to understand the different organisms, and then the culture and sensitivity, and then accordingly you have to use the antibiotics also. So don't use the antibiotics for only 1 day, 3 days or the 5 days in pyelonephritis. In pyelonephritis, you have to use a period of about 14 days to 28 days. Sometimes you have to use the nitrofurantoin for 3 months, 6 months also, or even maybe 1 year also. Whereas the uncomplicated UTI, even a single dose of azithromycin is sufficient. One day course is also sufficient. So see, this is a very big problem of UTI. Am I right, Dikshit? So now move on to the case study 2. There is about 60-year-old lady with 11 years history of the type 2 diabetes and hypertension. On therapy with the sulfonylurea and the metformin combination has been found to have the albuminuria of 1.5 grams per day. Retinal examination is the normal. So what is the working diagnosis here? 60-year-old lady, so post-menopausal woman with 11 years history of the type 2 diabetes. Diabetes plus hypertension. Okay. Therapy with sulfonylurea and the metformin combination. Albuminuria 1.5 grams. 1.5 grams albuminuria means nephropathy. Okay. Now what about the retina? His close friend? Normal. Now you are in a dilemma. Whether this retina and this neuropathy, protein excretion or proteinuria is because of the diabetes or non-diabetic. So what is your diagnosis? Could be diabetic nephropathy. Could be non-diabetic retinopathy, nephropathy also. So how would you further evaluate this patient? So what are all the causes of the non-diabetic kidney disease in a diabetic individuals? How would you modify the management? So when to suspect a non-diabetic renal disease in a patient with a diabetes? This is a very, very important. Okay. The short duration of the diabetes less than the 5 years. Okay, short duration. So usually in the type 2 diabetes, maybe at the time of the diagnosis itself, but the type 1 diabetes, so last year type 1 diabetes, this year already proteinuria. So not possible. So it will take minimum 5 to 10 years to cause the nephropathy. Absence of the retinopathy. So endure the ophthalmologist's opinion. Grossly elevated lipids. So massive lipid profile, deranged lipid profile. Sometimes we see the people With the last week, I have seen one patient with cholesterol 560, triglycerides 2400. Okay, LDL maybe 190 or 180. His weight 160 kgs. Blood sugar 450. His name Balaji from Petapuram. He doesn't want to admit. I am perfectly all right, doctor. Don't worry. I am perfectly all right, doctor. Don't worry. Then I told you all these things. See your weight. You are supposed to be the BMI this much. Now your BMI is more than 35. So you are morbidly obese. Number one. Number two, the diabetes is not under good control. Now already 400. You are at risk of getting the ketoacidosis also. Already the ketone bodies, I have to check and see the ketone bodies structure. And dyslipidemia is very, very high. So the obesity, uncontrolled diabetes, blood is very, very thick. At any given time, within a few minutes or hours, you can get a massive myocardial infarction or sudden cardiac death also. Okay, so these are the primary parameters. So now tell me, you want to admit or you don't want to admit? I want to admit, doctor. Okay, so then we give all the drugs like your fibrates I have given, statins I have given. Okay, I have started him on the insulin therapy. So for the proper speedy recovery of the hyperglycemia. Okay, so that's how we have to treat this population. So in such individuals, even though the fellow is having the creatinine maybe 1.6 or 1.7, maybe it is because of the massively grossly elevated lipids. So after the correction of the dyslipidemia, again the creatinine level also will come down. So active urinary sediment, hematuria, pyuria, CAS. So that shows urinary tract infections. Okay, hematuria, pyuria. Okay, so CAS. So these are all very important. History of the clinical features of primary renal disease preceding the onset of the diabetes. So the diabetes history is 2 years or 3 years, but it has been a known case of the renal problem for the last 5 years or the 10 years. So that is not because of the diabetes. So the kidney problem is there before the diabetes also. So in such cases, so this is all the non-diabetic renal disease in a diabetic patient. Am I clear? So workup of the suspected non-diabetic renal disease, kidney disease without the retinopathy. So get the ultrasound abdomen, a normal kidney size, get the renal biopsy. So renal biopsy is very much needed here. So ultrasound KUB, other causes of the proteinuria, get renal calculi or cysts or hydronephrosis or tumors or obstructions. That are contracted kidneys, ultrasound abdomen. So probably chronic glomerulonephritis or chronic pyelonephritis. So renal biopsy not indicated provided if their kidneys are very much contracted. So shows the chronic glomerulonephritis or the chronic pyelonephritis. Even then, so biopsy is needed because to know the exact pathophysiology in that. So in a non-diabetic kidney disease, we are suspecting a diabetic individuals. So the take-home message is get the kidney biopsy to be done to know the exact cause of that. Some people may be the lupus nephritis. Some people they may be having a NASIAD associated nephropathy. So treatment of the diabetic kidney disease, again see the glycemic control with your good drugs and insulin, blood pressure control with your ARBs, with your diuretics, with your ACE inhibitors or ARBs. And most of these people know the blood pressure control is very, very difficult in the CKD population. So yeah, there you have to use the resistant hypertension. So you have to use the 4th drug, 5th drug, 6th drug also. So spironolactone, some people they may have the finerenone, or some people they may use the beta blockers, vasodilatory beta blockers like your carvedilol, bisoprolol, nebuvolol. So sometimes you have to use the hydralazine, central acting drugs. So these are very important drugs to be used in, and sometimes narcomin. Okay, so that is also very important in the CKD population. Diet control is good, inhibition is good, RAS blocker is very important. So these are very, very important in a diabetic kidney. Suppose if you understand these all the 6, good control of the blood sugar, blood pressure, cholesterol. So ABC there. Here a good diet control, physical activity, cessation of the smoking, etc. Then the SGLT inhibitors, very good renoprotective, and RAS blockade is also very important in the diabetic individuals. So another case, type 2 diabetes for 18 years. He is 54-year-old, age is 54, has come for his annual checkup. So he got the diabetes at the younger age group. Okay. A1C 7.2, reasonably good. Blood pressure is 142/96. There is no postural hypotension. TMT is normal. Foot examination is normal. Retinal examination shows non-proliferative diabetic retinopathy. 24 units examination, 280 milligrams of albuminuria per day. Creatinine level is 1.3. GFR is 40. See, creatinine 1.3. What is GFR? 40. His medications, glimepiride 4 mg, metformin 1000, amlodipine 5. So what is your working diagnosis here? So diabetes, hypertension, because the blood pressure more than 140/90 is an hyper. Here systolic is there, diastolic is also there. So is an hypertensive. And then retina examination, diabetic retinopathy is there, non-proliferative diabetic retinopathy. And then urine, albuminuria 280. So normally less than 30. 30 to 300 is microalbuminuria. So is nephropathy. So retinopathy, nephropathy, diabetes, hypertension. So is the creatinine is 1.3 and GFR is 40. So GFR 40 means what is the stage? Stage 3. 3 is 30 to 60. 3B, you are right, 3B. Okay. 45 to 60 is the A, 30 to 45 is B, 3B. Medications include, so that is your working diagnosis. So medications, do you want any moderations, any alterations here? Okay. So does he need any addition or modification in his medication? So here SGLT inhibitor is not there. So if there is any room, you can add SGLT inhibitor here for a renoprotection. Okay. So if you want to add the SGLT inhibitor, you have to sacrifice the glimepiride. Okay. Or you can reduce the 4 mg to 2 mg glimepiride and then you can add the SGLT inhibitor. Okay. So his blood pressure is 140/2, 142/96. So you need medication. So what is the best drug to treat him? Antihypertensive. Is he getting? No, he is getting amlodipine. So this is Pakka Bandarlanka prescription. Okay. So he needs ARP. So he needs ARP. So add ARP. Because amlodipine not able to control the blood pressure properly. So keep the amlodipine. It is not nephrotoxic. Keep the amlodipine. Add telmisartan. So you can reduce the glimepiride and then you can add the SGLT inhibitor. So that is the best prescription here. Okay. Glycemic control has been unequivocally shown that tight glycemic.
In that case, you told it's, I think it's only stage 1 hypertension. Does it need combination therapy?
Yeah, he needs combination therapy because he already is on amlodipine. So his the control is good. Okay. So what is your target of blood pressure?
130.
Okay, 130/80. So it is more. So here two options for you. If you want to use the monotherapy, you can increase the dose of amlodipine. But what is the best drug to be used in the diabetics?
Yes.
He is not getting it. So then you have to add the ARPs. Am I clear?
What I'm asking is, can we change this to ARP alone instead of combination?
So alone, a single drug is not getting under good control. So again, you are going to the monotherapy. So not possible. Not possible.
That is near to 30, actually 40. Can you stop
మెట్ఫార్మిన్ GFR 30 అయితే స్టాప్ చేయాలి. స్టాప్ చేయని అవసరం లేదు. అంటే ఈజ్ గెటింగ్ ఓన్లీ 1000 కదా. ఈజ్ గెటింగ్ 1000. సపోజ్ ఇట్ ఇస్ 2000 అనుకోండి. అగైన్ యూ హ్యావ్ టు రెడ్యూస్ ద డోస్ టు 1000. సో ఈజ్ టేకింగ్ ద 1000. లెట్ హిమ్ కంటిన్యూ ద 1000. No problem. Or you want to reduce it, reduce to 500. But you have to use the metformin here because it's a good drug to reduce the resistance, insulin resistance. Otherwise, you need the insulin therapy. You got the point in it? So the glycemic control, it has been unequivocally shown that tight glycemic control prevents or delays the development of albuminuria in both type 1 and the type 2 diabetes. So the DCCT, UKPDS, Kumamoto, so the different studies are there. HbA1c reliably reflects the mean glycemic down to an EFR. Below this threshold, HbA1c values may be falsely low due to the shortened RBC lifespan. In such cases, SMBG or the CGM derived data may be used to guide the therapy. Renal failure and anti-diabetic drug therapy. Metformin already we discussed. Sulfurious also I told you. Repaglinide. So that is a good drug. Short acting sulfonylurea. Okay. So it reduces the postprandial hyperglycemia. So repaglinide is available in 0.5, 1 mg. Repaglinide alone, repaglinide plus voglibose is also available. Okay. So repaglinide 0.5 mg plus voglibose 0.2 mg. Or repaglinide 1 mg and then the voglibose 0.3. So the different strengths are available. So they are very safe in the renal field because of the shortest acting sulfonylureas. Glitazones and acarbose are best avoided because of the side effects, gastrointestinal side effects. Sitagliptin, Saxa and Velda, they are good drugs, but you have to reduce the dose. Linagliptin and teneligliptin, you need not change the dose adjustments. But teneligliptin is not cardiac safe, you can stop it. Insulin is safe, but at the cost of hypoglycemia. So you have to see that the hypoglycemia should not be there in the insulin usage. So you can use the analogs here rather than the regular insulin. So regular insulin cause a lot of the hypoglycemia. They have to wait for about 30 to 40 minutes before the food. If the food is delayed, so again they will get the hypoglycemia. So you can use the designer insulins or the analog insulins here, because in the CKD population they need very few amounts of the insulin only. They don't require 60 units or 70 units or 100 units like a non-diabetic, CKD population. CKD population, they need 5 units, 10 units, 15 units. That is sufficient. Like your GDM population. See the GDM, no, they need 5 units of the short-acting insulin before breakfast, maybe 5 units before the lunch. The blood sugars will be 80, 90, 100 only. If you use 15 units or 20 units, no, they will end up with the hypoglycemia. Pre-gestational diabetes is different. Pre-gestation, they need very large doses. We have to give the 4 shots or 5 shots a day.
Excuse me, sir. Sir, we didn't understand the previous slide regarding the HbA1c. It doesn't reflect glycemia if the GFR is less than.
See, there is some variations in the HbA1c. See, HbA1c is directly related with your RBC lifespan. RBC lifespan is 90 to 120 days. So in the presence of uremia, in the presence of the toxemia, metabolic toxemia, so the lifespan of the RBC will be reduced. So the same thing in the CKD also there will be anemia. So again the RBC will be at a lower level and hemoglobin is at a lower level. So this HbA1c is spuriously higher when compared to the normal population. So don't 100% depend on the HbA1c in a severe CKD population. You can use it, no problem. 30 minutes.
Which is the best marker so that it's not HbA1c?
అంటే continuous blood glucose monitoring or SMBG, fasting and the postprandial.
So they have to get admitted.
Fructosamine is also good, but it is only 15 days estimation. So more of your faculty, your specialty. So HbA1c in gestational diabetes, we don't use it. Only at the time of the diagnosis we do it to rule out the undiagnosed type 2 diabetes or type 1 diabetes. After that, if you want to get the control, fructosamine is much good because it tells you the 15 days duration of the control of the blood sugars.
It's fasting and
Substitute. You can use it, but no changes. But usually we decide only the HbA1c only. So depending on the patient's anemia, we can correct them. In glomerulopathies, in hemoglobinopathies, or sickle cell anemia, in such cases, falsely high. In nutritional anemias, falsely low. Here, this SGLT inhibitors already told you they are now recommended as the first line anti-hyperglycemic agents with the type 2 diabetes and the CKD. The GLP-1 receptor agonists is the preferred second line agents or can be used as the first line agents if the SGLT inhibitors are not tolerated. See, most of the times now, the SGLT inhibitors tolerance levels is low in some population because of the presence of the urinary tract infections and the genital infections. And also some people will have the dehydration also, SGLT inhibitors. So these are the mechanism of the renal benefits of the SGLT inhibitors. See the normal and the second internal one is the impaired TGF, and then the restored TGF. Okay. So in the normal appropriate efferent arterial tone and the macula densa, glucose and reabsorption, SGLT2 inhibitors, this is the normal physiology. It's a very, it's a clumsy slide, but the one thing is very clear that every day whatever the blood is there, that blood has to be filtered in the glomerulus. So whatever the filtration is there in the glomerulus, all the blood in the filtered, again all the filtered glucose will be reabsorbed. So that is the reason no glucose appears in the urine in a normal individuals. So every day around 180 grams of the glucose will be filtered, and again 180 grams of the glucose will be reabsorbed. So by using these SGLT inhibitors, they prevent the reabsorption. So what will happen to the filtered glucose? That will be passed into the urine. So that is causing therapeutic glucosuria. So those people are an SGLT inhibitor. If you check the urine sugar, it will be 4+, because you are making the therapeutic glucosuria. So that is your this. That is the reason entire urethra, entire the tract is filled with the glucose. So inviting lot of bacteria to be infected. So the urinary tract infections or the monilial infections are more common because of these reasons. So the dehydration is also very common, because along with the glucose, the sodium also will come out. So water also will be come down. So they will be having more polyuria, more nocturia, and also electrolyte imbalance. So they cause some dehydration. So the blood pressure, already I told you, very, very important blood pressure management. See, if you ask me a direct question that is the blood glucose control is good or blood pressure control is good, is more important, vital. So I think the blood pressure control is much more important than the blood glucose control, because what are all the complications of the diabetes will be multiplied 3 times, 4 times, several times in the presence of hypertension. So all the diabetics, if the patient is also hypertensive, give equal importance or much more importance to reduce the blood pressures in the presence of the diabetes. Am I clear? So don't underestimate the importance of the BP lowering in a diabetic individual. So the BP lowering in a diabetic individual is a very, very important step to avoid the long-term complications or to reduce the long-term complications. So blood pressure levels less than 130/80 are generally recommended to reduce the CVD mortality and slow the CKD progression among all people with the diabetes. Lower blood pressure targets should be considered for patients such as those with the CKD based on the individual anticipated benefits and the risks. ACE inhibitors or ARBs, they are the preferred first-line agents for the blood pressure treatment with the diabetes, hypertension, GFR less than 60, and urinary albumin excretion more than 300 milligrams. Diabetic patients without albuminuria, ACE or ARBs are not superior to other classes of antihypertensives for the BP control. So without the albuminuria, you can use either the calcium channel blockers or the beta blockers or the diuretics, etc. But mostly use the ACE and ARBs. Most patients will require more than one class of antihypertensive agent to reach the BP goals. That is very important. So most of our people, they need combination therapy, at least 2 or 3 agents to reduce the blood pressure to an effective level in a diabetic individual. They prevent the progression of CKD in patients with urinary albumin excretion. In patients with urinary albumin excretion with 30 to 219, that is microalbuminuria, they reduce the progression to higher levels of albuminuria as well as the CV events. So it is a reversible one once the urinary albumin excretion is up to 300 mg. The role in patients with abnormal without hypertension is less clear. They are not indicated for prevention and development of the albuminuria in patients without hypertension. See, recently, the mineralocorticoid receptor antagonist, finerenone, that already told you, has been shown to reduce the progression of the kidney disease in patients with type 2 diabetes and albuminuria. Now, the finerenone is the most demanding drug, most wanted drug in type 2 diabetic individuals to reduce the long-term complications like CKD or ischemic heart disease or the heart failure, etc. So, if the patient can afford in high-risk type 2 diabetic individuals, we can use the finerenone, 20 mg and 10 mg. ACE or ARB, no long-term trials comparing the two classes. Short-term trials show the similar reductions. There is more evidence that ACE in type 1 diabetes and ARBs in type 2 diabetes. That is the reason we use more of telmisartan and etc. sartans because most of our patients are type 2 diabetics. Type 2 diabetes. Use of ACE plus ARBs in combination is not recommended except in the hands of a senior most nephrologist.
Proteinuria diabetic patients without hypertension. Can you start low dose ARBs?
You can use it. You can use it because they are not potent antihypertensive medications. Suppose if you use your Cardace or Ramipril or your Telmisartan 20 milligrams, they are not a potent antihypertensive medications. So 20 mg of the Telmisartan or 2.5 mg of the Ramipril, you can use it. So contraindications, you know that pregnancy you should not use ACE or ARB or diuretics. So these are very important. So in pregnancy, you use only calcium channel blockers or beta blockers or combined alpha beta blockers like labetalol or central acting drug like alpha methyl-dopa. Bilateral renal artery stenosis, it's a big contraindication. Intolerance, especially the dry cough, more with the ACE inhibitors, then you can change out to the ARB. Still the person is having the cough with some particular ARB, change another ARB. Suppose they're getting more cough with the telmisartan, change to other sartan. Hyperkalemia, a big contraindication. Moderate to severe aortic stenosis, so don't use it. Worsening the renal function. RAS blocker in the diabetic kidney disease, a non-steroidal mineralocorticoid finerenone. It has been shown to reduce the progression of the CKD in patients with type 2 diabetes and albuminuria. Indicated in patients who are at high risk of CKD progression, persistent albuminuria in spite of the maximum tolerated dose of ACE or ARB. With persistently normal serum potassium and monitor the potassium levels regularly. Hold if the levels increases more than the 5.5. So again, you have to respect the potassium, not only for your ACE or ARBs, but also to your finerenone therapy. Contraindicated if the GFR is less than 25. Dosage is 10 if the GFR is between 25 to 60 and 20 when the GFR is more than 60. You can remember the 30. So for your metformin and etc. you are remembering 30. So here also up to 30 to 60 you can use the 10 milligrams. More than the 60 you can use the 20 milligrams of the finerenone. Can be used in combination with the SGLT inhibitors, ACE, ARB. But when you are using the ACE and ARB with the finerenone, the chances of hyperkalemia will be high because ARBs will cause hyperkalemia, finerenone also will cause hyperkalemia. So in the presence of the hyperkalemia, you have to use these drugs at a lower dosages. So take care of these drugs and check the potassium levels. So dietary restrictions. So Indian diet is low in the protein and is mainly of the vegetarian origin. Hence, protein restriction is often not needed in the Indian patient. That already I told you. Sodium restriction is a very, very, very important. So salt restriction is very important. Just 1 spoon. So that is about 2.5 grams, 2300 milligrams. So 1 tablespoon is sufficient per day per individual. That is our sodium restriction. So avoid the nephrotoxic drugs like NSAIDs, radiocontrast material, dehydration, smoking. Early and aggressive treatment of the UTI is very much needed. Otherwise, these people will have pyelonephritis and ascending infection, etc. Sodium and phosphate restriction as and when indicated. Lipid lowering therapy, especially statins. They are the HMG coenzyme A reductase inhibitors. You have the atorvastatin or rosuvastatin. Refer to the nephrologist if the creatinine rises or hyperkalemia is present or when the GFR drops below the 30. So another case, a 70-year-old male, a 15 years history of type 2 diabetes and hypertension, on therapy with the glycoside and the metformin, complaints of the increasing swelling of the feet. BP 160 by 100, urea 60, creatinine 1.5, cholesterol 120, triglycerides 180, fasting 280, postprandial 380, potassium 5. So what is your working diagnosis?
Uncontrolled hypertension and also.
One is male, elderly male, okay, 70-year-old. Then the diabetes, then the hypertension, okay, diabetes and hypertension. Now the CKD, okay. So urea and creatinine are elevated. And any dyslipidemia, cholesterol 120 and the TG 180, okay. And uncontrolled blood sugars, fasting and PP way high. And there is Normal potassium. 5.5 is the hyperkalemia, up to 5 is the upper normal. You have to respect this. Otherwise, no, this 5 will become 5.5 within no time. So that you have to respect. So what is the working diagnosis here? In a 70-year-old, diabetes uncontrolled, hypertension uncontrolled, and then already had CKD and know the stage because the creatinine 1.5, here the male and also the age. So 70 is the age, sex is the male, and creatinine is 1.5. Then you will get the creatinine GFR. Maybe GFR may be here, or maybe 40 or 45. Okay, already the stage 3 or the stage 4 here. And the potassium is upper normal. So how would you further evaluate this patient? So because the fasting and PP are very high. So what is the drugs here? The creatinine level is already 1.5 and urea is rising up. Yes, better is the insulin always. So any metformin role here? No, in the uncontrolled diabetes means at high risk of getting the metabolic acidosis. So the metformin will increase the metabolic acidosis risk, hypoxia risk. So don't use metformin here. Don't use sulfurias here. Don't use thiazolidine here. Don't use the gliptins here. SGLT inhibitors also uncontrolled diabetes means not ideal. So preferably insulin, here insulin. For the diabetes, for hypertension control, 160 by 100. Potassium is already 5, upper normal. So use with caution, ARB. Okay, and you can use the diuretic here, and you can use the calcium channel blocker. Like amlodipine or cilindipine here. Swelling of the feet. So you can use the diuretic. So which diuretic you use? Loop diuretic, preferably loop diuretic, like spironolactone or the torsemide. Okay, Fruslac or the torsemide. So these you can use. So this fellow is going to the failure also. Heart failure also. So cardioprotective drugs. So this is how the manage the ESRDs. So GFR less than 30. Will renal replacement therapy be appropriate? No. Manage as per no renal failure with low protein diet and diet and symptomatic treatment. Suppose renal replacement therapy is needed. Yes. Suitable for renal transplant. Yes. Tissue typing, renal transplant, and keep the creatinine level around 5. Not suitable for renal transplant because the age or maybe because of the associated other things. Then suitable for CAPD, peritoneal dialysis, because it's very costly. Yes, you can go for the peritoneal dialysis. Otherwise, form the AV fistula. This is very important. And then the hemodialysis. So most of our patients, they fall under here hemodialysis. So again, making the AV fistula is also a big task in the diabetic individuals. So the vessels will be very tortuous, and then failure of the AV fistula is also very common in the diabetic individual. And then the infections there. So this is very important. You should not check the blood pressure on the hand of your AV fistula. So some precautions you have to take it. But AV fistula is very important. It's a big boon for the nephrologist to have a frequent dialysis. So this is very important. So another case, 64 years, comes to you with the complaints of swelling of his legs for the last 6 months. Type 2 diabetes from the age of 42 years. Now already 22 years history of diabetes. He has undergone the laser photocoagulation for proliferative diabetic retinopathy. So already retina treatment is under laser therapy. His blood pressure is high, almost 170 by 100. Investigations, fasting 88, PPG 118, HbA1c 6.6. Urea 78, creatinine 4.2. See, remember that in any diabetic, uncontrolled diabetic, recent fast, you are seeing the normal blood sugars. Always think of renal failure. Am I clear? So all these years, his blood sugars are very high. Now he is coming with the normal blood sugars. Okay, then what investigation you are supposed to write? Creatinine levels, urea creatinine, to check whether the patient is in the DKD or not. Once the CKD is involved, started, then these people will have hypoglycemia and the blood sugars will be the normal here. See here, fasting 88, అది చదివేటప్పుడు నాకు అర్థమైపోయింది. His creatinine somewhere between 4 and 5 అని. So fasting is 88, postprandial is 118. Out is the BP. BP is very high, 170 by 100. Okay, so that means he is in the CKD. Urea 78 and creatinine 4.2. It is not AKI. AKI means urea will be 180, 200, and creatinine will be 2. So the elevation of the urea will be much more when compared to the creatinine in acute kidney injury. Whereas in a chronic kidney injury or in a chronic kidney disease, so your creatinine level will be much more when compared to the urea. Here the upper normal of urea is 40 or 45. Here is 78. Whereas the normal creatinine level is 1. 4 times elevation here, 4.2. Okay, but urea is just elevated 1 time or maybe 0.5 times or 0.6 times. So that is very important here. His ultrasound abdomen shows normal sized kidneys. So sometimes it shows you the contracted kidneys also. His medications include glibenclamide 10 milligrams, stop immediately. Sulfonylurea, hypoglycemias. Metformin 1000 milligrams, that also you can stop. Atorvastatin 20 milligrams, you can use 10 milligrams or you can continue the 20 milligrams. Ramipril 10 milligrams. Again, creatinine is at 4.2 and potassium levels, they didn't check the blood sugar, potassium level, check the blood sugar, potassium level. If it is 5.5 or the 6, stop using the Ramipril also. Aspirin 150 milligrams. You can continue or you can reduce the 75 milligrams also. So this is how you have to give the adjustment in the dosages. So here you have to stop using the glibenclamide, stop metformin, stop ramipril, and then continue the atorvastatin, continue the aspirin, maybe at a lower dosages, and then treat the diabetes. So treat the diabetes accordingly. So you can treat with insulin only here, with a lower dose of the insulins. Okay. Maybe more less because already the creatinine is 4.2. 4.2. So you can want to use the gliptins, you can use the lenagliptin. It can be used at any amount of your creatinine levels. Or if you want to use the SGLT inhibitors, so again the creatinine level, the GFR will be maybe here in this case maybe 20 or 25. So less than the 30 you should not use the SGLT inhibitor even though it is a renoprotective drug. ARBs, again our hands are tied because already creatinine level is 4.2. So creatinine level is 4.2. If you use the AS or ARBs, the people will have hyperkalemia and hyperkalemia will introduce the erythmias and there will be the sudden cardiac death. So that's all. So what modification is needed in this patient? For diabetes, insulin. For hypertension, calcium channel blocker. Diuretic. High dose of the diuretics. Not 40 milligrams of the Lasix. One tablet, not one tablet of Lasix. Maybe 2 tablets, 3 tablets, 4 tablets. In US, even the 400 milligrams of the Lasix is also available. Furosemide is also available. 400 milligrams. In India, it is not available. Okay. So 10 tablets of the Lasix is equal to 1 tablet of the Lasix in US, 400 milligrams time. So you can use the maximum dose of the diuretics also here. Maybe the loop diuretics is the answer here, not chlorthalidone or hydrochlorothiazide. So use the loop diuretics, use the insulin, use the calcium channel blockers, use the beta blockers if needed, like your carvedilol or bisoprolol. So use the arcamin here for BP protection. You can use the alpha blockers like Minipress XL, Frazosin. Okay, that also good nephroprotective antihypertensive drug. So that's how you have to attack the hypertension here. So glycemic management. Yes. See, requirements of the insulin and other anti-diabetic medications is due to the decreased renal and hepatic insulin clearance. Why there is more and more hypoglycemia? Because of the decreased renal and hepatic insulin clearance, a decline in the renal gluconeogenesis, deficient catecholamine release, a diminished food intake, protein energy wasting, and the hypoglycemic effects of the dialysis treatment. These are all the reasons for the hypoglycemia in a CKD population. Patients will require de-intensification of the treatment with avoidance of the medications likely to cause hypoglycemia. So we should know what are all the don'ts. First learn don'ts in the CKD. So in all the cases, so don't use the ACE inhibitors or ARBs or SGLT inhibitors or the metformin when the GFR is less than 30.